To present his paper, Dr. Pankaj, please. Use of platelet-rich plasma and bone marrow aspiration concentrate injection to treat knee osteoarthritis. Pankaj.
I am here to talk about use of platelet-rich plasma in osteoarthritis. Now, in early osteoarthritis, can we do anything promising from the traditional treatment options to help the patients? Now, the various traditional treatment options are rest and braces, physical therapies, medications, intra-articular steroids, and of course, surgery. Is there something wrong about these traditional treatment options? For the rest and braces, physical therapies, no. But the medications, yes, they do cause ulcers, gastritis, systemic disorders. Intra-articular steroids, yes, they temporarily reduce the inflammation, but they inhibit the healing process and cause cartilage and soft tissue damage. Surgery, they of course has intra and post-operative risks. Any other options? What about platelet-rich plasma? It is a natural way to stimulate the body to heal the damaged tissues. Now, it is defined as a volume of plasma that has the platelet count above the baseline of the whole blood. That is 10 lakhs per ml or 3 to 5 times that of the peripheral blood. It was first developed in 1970 and used in 1987 in open heart surgeries. It gained popularity in mid-1990s for the treatment of arthritis, ligaments, and tendon injuries. Now, the types are pure PRP, leukocyte-rich PRP, pure platelet-rich fibrin, and leukocyte and platelet-rich fibrin. Some of the new techniques are titanium plates having enmeshed PRP. Now, the preparation of PRP, standard PRP preparation method and Buffy coat method, where we collect around 27 ml of whole blood and we centrifuge it with an anticoagulant, ACDA. Then we centrifuge it with 1900 grams of 1900 gram centrifugal force for around 5 minutes, and then we get 3 layers. First is the platelet poor plasma layer, then is the Buffy coat, and last is the RBC concentrate. So we separate the upper and the Buffy coat to another tube, and then we give another 1900 gram centrifugal force for around 10 minutes. That is called hard spin because the rotations are higher. So this is the method. So the process of injecting is like any other intra-articular injections. We can use any of the methods you like. Now, arthritis, the problems are cartilage wears out, poor lubrications, and the resultant inflammation which causes pain. So the bad molecules which causes the inflammation are matrix metalloproteinases, collagenases, interleukins 1, tumor necrosis factor, and disintegrins. They mainly cause catabolic breakdown. And the good molecules are tissue growth factors, tissue inhibitor of metalloproteinases, interleukin receptor antagonist proteins, and alpha-2 macroglobulins. They block the bad molecules. So what the platelet-rich plasma does is reduce the bad molecules and increases the good molecules. It augments the tissue healing through the natural healing cascade. This cascade consists of 4 steps, that is chemotaxis, cell differentiation, cell proliferation, and angiogenesis. Like during PRP therapy, it conveys the fibrins and the growth factors as effectors. So these growth factors affect on the entire joint and promote the restoration of joint homeostasis, inductive and protective effects on the chondrocytes. It stimulates the hyaluronic acid production by the synoviocytes. And all these properties help to promote a generative biological environment and to slow down the joint and cartilage degeneration, thereby relieving symptoms. Like some of the uses in orthopedics are knee osteoarthritis, lateral epicondylitis, rotator cuff injuries, non-union like titanium enmeshed plates, Achilles tendinopathy, patellar tendinopathy, plantar fasciitis, wrist arthritis, ankle sprains, and shoulder osteoarthritis. Like outcomes, the Kohn et al. In a study of 150 patients who received PRP, they gave better clinical score at 12 months. Spakova et al. In study of 120 patients found significantly better results in the WOMAC scoring. Like numerous studies have been done previously in the past and still going on. Smith et al. In 2016 did a comparative study between PRP and placebo group, where he injected a normal saline in one set of patients and in one set of patients PRP. He found that from 2 weeks onwards, PRP was significantly superior to the saline placebo up till 12 months, and it improved the WOMAC scoring. Sarza et al. In 2012 compared the results of PRP versus hyaluronic acid, and the results were PRP showed significantly better clinical outcome than treatment with hyaluronic acid, but the effects were limited only up to 6 months. So treatment with hyaluronic acid does not seem to be effective in the patient with grade 3 osteoarthritis. Kanchat 1 in 2015 suggested that PRP injection is more efficacious than the hyaluronic acid and placebo in reducing symptoms, improving function, and improving quality of life in patients with mild to moderate osteoarthritis of the knee who have not responded to the conventional treatment and therefore can be considered as a treatment of choice. Now, RN Singh sir has already talked about bone marrow aspirate, but it has been taken from the posterior iliac crest, and usually 2 ml of this bone marrow aspirate has been taken, we took and been given into the joints. These mesenchymal stem cells are the multipotent progenitor cells that can be obtained from the bone marrow, adipose tissue, synovium, articular cartilage and skeletal muscles, and they present self-renewal and differentiation potential. So the advantage of mesenchymal stem cells are they are autologous, there are no major ethical constraints, they can be expanded in vitro, they can be cultured, and they do not express HLA2 antigens. But their mechanism has not been fully understood, and the hypothesis is these mesenchymal stem cells potentially provide a direct cell source for the tissue repair. And these nucleated cells have a paracrine effect by delivering the various growth factors and cytokines into the lesion site to promote the tissue healing and immunomodulation. These mesenchymal stem cells also have immunosuppressive effects by adjusting the activation of natural killer cells, dendritic cells, macrophages, and TNB lymphocytes. Thus, the mesenchymal stem cells have advantageous anti-inflammatory and anti-fibrotic actions to maximize their therapeutic effects. In conclusion, the platelet-rich plasma and the bone marrow aspirate are successful modalities for the conservative management of osteoarthritis, as it not halt the progression of disease but also the bone healing. Thank you.
Thank you, Dr. Pankaj. Please stay back and receive a memento from Secretary BOA, Dr. Mahesh Prasad, sir. It was a wonderful talk, Dr. Pankaj. Dr. Ashish, do we have ample time? Can we invite a few questions?
Yes, sir.
Okay. So, the House, we invite questions from the delegates. Questions from delegates to all the speakers for this session. So, Dr. Pankaj, as we don't see any questions from the House, in the meantime, could I ask you a couple of questions?
Sure, sir.
So, I have question related to your topic, which is in 2 parts. Firstly, your personal experience regarding PRP use in clinical practice, number 1. And number 2, there might be many of us who do not have a regular access to a centrifuge at our clinical setups.
Yes, sir.
How can they bring about doing this procedure?
Sir, I have seen that these corticosteroids and this hyaluronic acid they are usually effective in the first 6 months. That is, their time of action is fast. The patient gets immediate relief. But the platelet-rich plasma, they actually cause inflammation and reduce the inflammation and immunomodulation. So the actual improvement occurs after 2 to 3 months. But we have to give the same protocol has to be given for this, like we give in corticosteroids, like 3 weekly intervals, like for PRPs also, for 3 doses. Then after 6 months, some patients have reported good improvement. And so it has been given only in stage 1 or stage 2 osteoarthritis only, because grade 3 and grade 4, they do not have reported any significant improvement.
Would you advocate, I'm interfering you, the second part you can answer. Would you advocate the use of some other NSAIDs or steroids initially so as to give the patient some immediate relief so that he could
Yes, sir, we can do
feel more confident on you and you
Yes, sir,
could
we
win
can
his
do that.
confidence. Okay.
Like first time we can give corticosteroids, and after 3 weeks, we can give platelet rich plasma for 3 doses.
Okay, that now the second part.
The second part is, sir, if we have a center who wants to give platelet rich plasma, so if they don't have any means for the centrifugation, what they can do is extract the blood and mix the with anticoagulant like adenosine citrate dextrose acid like ACDA, like 27 ml of blood and 3 ml of anticoagulants, and they can send it to a pathology lab where they will first centrifuge it and they will extract the platelet poor plasma and the buffy coat, and then they have to spin it again, centrifuge it again for around 15 minutes, and then that excuse me, and then they can send it back to you. So this process takes usually more than 1 hour. So that's why we have to use anticoagulants when we don't have a center for that PRP.
Thank you so much.
Sir, generally it is said that steroid should be avoided in weight-bearing joints. What do you say?
Sir?
Steroid should be avoided in weight-bearing joints like knee.
Yes, sir. But if the patient is having synovitis and some sort of, then it has been found useful, I think.
Thank you.
Thank you, sir.
Very thank you for this conducting this wonderful session.